a 58-year-old female presents with progressive, localized right-sided chest wall pain and a palpable, tender lump. I am showing you her posteroanterior chest radiograph and an axial contrast enhanced chest computed tomography scan. Describe the findings.
The chest radiograph demonstrates a well-circumscribed, soft tissue mass in the right mid to outer hemithorax. The mass forms obtuse angles with the adjacent chest wall, showing a smooth medial border and tapered edges, suggesting an extrapleural or pleural origin. The axial contrast enhanced computed tomography scan reveals that the mass is centered in the chest wall, causing extensive osteolytic destruction of the adjacent rib cortex. The mass demonstrates intense, homogeneous contrast enhancement. These findings indicate a hypervascular extrapleural chest wall mass with associated rib destruction. In an adult, this is highly suspicious for a hypervascular metastasis.
How do you differentiate a pleural mass from an extrapleural or chest wall mass on imaging? And what are the two most common causes of an extrapleural mass with associated rib destruction in an adult?
Both pleural and extrapleural masses typically form obtuse angles with the chest wall. However, the presence of associated rib abnormalities, such as cortical destruction, bone remodeling, or expansion, is the most helpful differentiator pointing to an extrapleural or chest wall origin. In an adult, the two most common causes of an extrapleural mass with associated rib destruction are metastatic disease and multiple myeloma or plasmacytoma.
What are the two most common primary malignancies that produce hypervascular chest wall metastases? And what is a critical safety precaution regarding biopsy of these lesions?
The two most common primary malignancies associated with hypervascular chest wall metastases are follicular thyroid carcinoma and renal cell carcinoma. A critical safety precaution is that we must absolutely avoid blind, percutaneous biopsy of these masses. Because they are highly vascular, there is a very high risk of life-threatening hemorrhage. If tissue diagnosis is necessary, it must be performed under strict image guidance, such as computed tomography, with preparations for immediate hemostasis, and ideally following pre-biopsy angiographic embolization. I would recommend referring the patient to thoracic oncology, endocrinology, and interventional radiology.